Hello, and welcome to our overview of Chapter 9, Improving Quality in Healthcare Organizations. Now, Chapter 9 has a few extra slides because Chapter 9 happens to be my background. I'm Dr. Ashley Parks, and I've been a quality improvement professional for a very long time. Quality improvement is really central to what we do as health services administrators and to organizational behavior. And so it helps us demonstrate our efforts to improve to regulatory agencies. So we have that element where we have to show what we're doing, but also internally, the true commitment to growing and learning and changing is really key. So we want to decrease medical errors. We want to enhance patient safety. We want that to be true to our identity and our vision and our mission as an organization. We also want it to be very obvious to those who accredit and license us that we're doing that work. Now, one element of quality improvement in healthcare is how we set and measure objectives and data. So we look at objectives, we look at process, structure, and outcome measures, and we work to provide safe, effective, patient-centered, timely, efficient, and equitable care. So this slide here is meant to break apart those types of measures or objectives. So we have structural, process, and outcome. You'll notice the structural are the resources we have. Do we have the staff? Do we have the financial resources? Have we allocated them appropriately? The process is, are we doing things correctly? Are we in compliance? Are we timely? Are we operating with equity? And then the outcome is, do we have a low mortality rate? Do we provide effective treatment? Do we have the outcomes that we want to see on disease-specific measures, right? And so looking at that final outcome, that is evidence of the good work we've done, process. That is evidence going back to having the right structural pieces in place. So quality improvement is at a high level an organized approach to planning and implementing any sort of effort to keep doing better, continuous improvement. We emphasize examining what we're doing all the time, continuous examination, reflecting back, and working with teams to make improvement. And we want to make sure that the processes, the way that we're doing things, the steps make sense. All right. So in order to do so, and here's an example of some quality improvement data that I used in my career. This is the average time to an authorization going down over time, even though our patient volume is going up, right? So we track data over time to make sure that we're doing a good job. Now, we have many different types of quality improvement interventions in healthcare. For example, we may have externally developed QI measures, right? Things that the Joint Commission or the State Department of Health and Human Services wants us to do. The Center for Medicare and Medicaid Services, CMS, has specific guidelines, right? So those are specific to what we need to do. But we also have locally, internally developed QI efforts, things we just want to get better at. Maybe we want higher rates of employee satisfaction. That's not something that might be mandated, but we want to do that work. And so sometimes it's external, sometimes it's internal. Now, there's all sorts of measures that we use, things we track over time, and sometimes we call them a measure or a measurement. Sometimes we call them an indicator, but essentially, it's some piece of data or information we're tracking. And I guess we have structure, process, and outcome. Structure being whether or not we have the resources we need to meet our goals. Process being the activities involved. And outcome being the work performed. What was the result of that? Did it work? So that's our outcome. Now, this is an example of a page, and you'll notice on the side I have a list of measures. This is an example of a project that I executed where we looked at average referral turnaround times and patient retention. Did they stay in our health plan? Did they show up to their appointment? Many of these are process measures. Some of them are outcomes, right? But whether or not we did the referral quickly, it's a process measure. Whether or not they decided to stay with our health plan and were satisfied, that's an outcome measure. And so there's a lot of different measures that we look at in hospitals and in health plans and in outpatient settings, but there are really key ones that most people use. And an example of that is Leapfrog. Leapfrog is an external group that will come in and grade A through F a hospital facility. And they provide an assessment based on data that's submitted to them, whether or not you're providing appropriate care. Now, good quality measures are economical. We don't break the bank collecting the data. They are timely, right? We're able to look at it and reflect quickly, and they provide us something that we can act on. And so that's important. And so these are some examples of quality measures that fall under each of the broad categories, things like quality of work life, financial metrics, patient satisfaction, right? Achievement of strategic goals, safety, equitable and efficient care. So you can see there's lots of measures that we look at. These can be ones that were, from the Institute of Medicine, something they recommended. It could be something that's an organizational developed internal metric, right? Like your organization may choose to look very closely at whether or not your processes and your outcomes are aligned with the strategic goals of the organization. Are you hitting goals that you set at the beginning of the year? And that's very personal, organization-specific process of setting those goals and hitting those goals. Now, there's a lot of different approaches to quality management, but the next few slides are going to discuss one specific method. We're going to talk about PDCA or PDSA for a moment, and then we're going to talk about Six Sigma. Many quality improvement methods have slightly different variations to them, but all center around this idea of solving a problem and monitoring data, and then going back and revising our approach if needed, right? So it's a very common posturing. PDSA, or what's sometimes referred to as PDCA, Plan, Do, Study, Act, or Plan, Do, Check, Act, is a model for improvement, where we plan an intervention, we look at all the data, we come up with ideas, we do that work, we make that change, we study whether or not it worked or not, we follow up with the data, and then we tweak it again. We make some additional changes, we act. And so the PDCA, PDSA cycle is the same. It's just sometimes we use the word study, some people use the word check for that third step. Either way, that involves looking at the data and seeing if what we did worked. This is a high-level framework. It's also referred to as the Shewhart cycle. It was developed by a management scientist by the name of Shewhart, a quality improvement professional. And so this is a very common framework that's been around for a very long time. That being said, the last 20 years, healthcare has been taken by storm by this newer framework that's come over from manufacturing and engineering, from Toyota and Motorola in Japan, and it's called Six Sigma. And so Six Sigma, that's often paired with Lean, they're two frameworks, is a framework that looks at defining a problem, measuring the data, analyzing the data, implementing an improvement, controlling that improvement, tweaking, making sure it sticks, making sure you've, optimized it. That is a cycle. And if you look, it's almost identical to PDSA. I mean, very similar. The difference is that there's a little more specificity in the phases. And most Six Sigma professionals, like myself, I'm a Six Sigma black belt, and you may be interested in getting a Six Sigma certification at some point. Most professionals who learn Six Sigma learn specific tools. So there are tools that we leverage during the analyze phase, right? So we're talking about statistical process control charts and failure mode effect analyses. There's these tools, and we actually talk a lot about that in another course that I teach. That's the 3590 course, which is our quality improvement course, right? This is just a brief lecture on what is actually an entire course in the program. All right, so these are some key terms, this slide and the next slide. I encourage you to pause and take a look and reflect. Many of these terms overlap. Many of them are similar, right? When I talk about a quality improvement measure versus a metric, some of those definitions are near identical. But the idea of being a high performance organization, being a high performance high reliability organization that has high performance work practices, right? That's really our goal. And so these are some definitions for some of the terms that I'll be using in a moment. Now, when we implement quality improvement efforts, we have to realize that sometimes there's a big gap between an innovation, a new good idea, and it happening. And so sometimes we're innovating in real time, sometimes we're adopting things that were developed years ago. Either way, we want to implement new ideas that are effective, we want to track data, and we want to make them better. Now, this is an overview of industry features, the contribution to implementation failure, and key principles for success across different domains. So if we look at nature of work, if our work has a high level of uncertainty, a high level of risk, if it hinges on what clinicians, providers want to do, that impacts what we do. So those are features of the healthcare industry that create barriers and sometimes failures in implementation. But there's some approaches in our last column to addressing the nature of work in healthcare. There's also some, if you go to the bottom, it's performance measurement and control systems. We don't have always the best technology in some of our facilities. We don't always have the best access to data and information, but also the newest medications and certain components. And so we have to involve our workforce in developing and implementing new components. So this is a list of problems, and we have a list of solutions. And most of what that graph or that chart really tells us is the nature of work in healthcare. There's so many challenges, and I specifically want to focus on 3 really quickly. One of the challenges is risk and risk aversion. We don't want to hurt people, and therefore sometimes our hands are tied. We have to be very safe and very careful in what we do, which slows innovation, and appropriately so, right? We also have to be aware that there's certain work norms in healthcare. For example, why would a physician work a 24-hour shift? That's ridiculous to me, right? But that is a norm that's been established in the industry. And then we have clinical discretion. And clinical discretion means that doctors, physicians, providers are dictating what we do. And so as administrators, that is part of the nature of work in healthcare and what we have to work around while making positive change, right? Now, there's a lot of workforce characteristics. And if you notice, these slides are breaking down that table before, which is why I went through it so quickly. Our workforce is highly specialized. The interactions between physicians and patients and physicians and staff members, we've already talked about that a little bit, but it's sensitive. There's a hierarchy that emerges there. And how we identify ourselves as an organization can sometimes limit the types of services we provide, the manner in which we spend our money, and how we decide to engage with the community. And so these are all workforce-related issues. And we also have to think about the data. Do we have the time, energy, money, technology to collect information to incentivize behavior? Do we have those systems in place to really look at nursing effectiveness, to really look at issues that are arising in our facility? Do we have all of that data set up and scaffolded appropriately? All right. There's a lot of approaches that we can take. And we use this term IPPs, implementation policies and practices, which are implemented to help facilitate implementation. So anytime we roll out a new process, we develop a workflow, we develop a written policy so that we feel equipped to do that work. And of course, we have to have the right structure in place, the right culture and communication. We have to have funding. We have to have the support of governance, be it the governing board, the administrative leadership, and the physician leadership. Now, there's a lot of different quality improvement frameworks we can apply. Many of them frame QI as a learning challenge, which is why this chapter is paired with our continuous improvement and learning chapter we just went over, right? That idea of understanding we don't know it all. We need to improve. And as we improve, we're going to make mistakes. It's a learning challenge. It also helps us develop our own identity as an organization, coming around a problem and solving it together, using transformational leadership processes to make major changes in the organization, and developing, and of course we involve the workforce to do so, but we develop incentive plans and bonuses and ways to align our goals with our financial reality. Now, quite often we're trying to gather evidence and data in order to justify an intervention or in order to understand current performance and decide what to do next. And so when we're building that evidence, when we're pulling it together, sometimes we're asking our internal stakeholders what they think. Sometimes we're looking at what was successful in other organizations externally. Now, one of the key elements to being successful is perception management. Not only do I need to make a positive change, people need to believe it was effective. And that's half the battle sometimes, not only doing your job well, but making sure people see it. And so you may say, hey, we implemented this new technology and it was wonderful and it saved lives, but it took a little longer, so all the patients were unhappy. Well, that's not good. We have to find a way to get positive perception in our organization around new implementations, get people to believe in the idea before we implement it, and then make sure that we're marketing it and messaging appropriately to where people embrace it afterwards. People need to believe in the reason for the change. They need to know it's necessary. They need to feel that drive for change and feel discomfort staying where we're at. Now, when we're pushing change, when we're saying we've got to implement new systems, we've got to implement new processes, we have to do better. We have to realize that quite often there's this perception as reality perspective. People think it's fine. It's fine. Now, that might not be true. The patients might not be fine. But that happens. That perception can really be a defining factor. The other thing is we have to be real that we cannot implement a ton of change at once. You cannot make 5, 6, 7 large changes in an organization in a single month without creating fatigue for your staff. Now, there's a lot of ways that we measure and incentivize healthcare quality in the United States healthcare system. This graphic here is a little dated, but I like it because it shows this major change that happened between 2016 and 2018, where more and more health plans started implementing some sort of alternative payment model where they were paying based on quality. And so you'll notice in one span of 2 years, we went from only 30% of health plans using some sort of alternative payment model to 50%. And that continued to grow from there. But when you just look at the fact that in the ACA was enacted, there were some major changes, and then all of a sudden that growth, that boom started to occur of realizing, oh, maybe we should pay people based on metrics, based on measures of how good the care is. Now, when we do that, we're trying to incentivize something. And so we have to collect the data, which can be very cost prohibitive. It can take a lot of work to do that. This graphic here is saying that our current health system, the cost and the utilization is not sustainable, and why. It's comparing the US to Australia and the UK, Germany, etc. We already know that. We know it's not sustainable, but we have to decide, how do we realign the funds to incentivize the right behavior? Now, this slide here has some interesting data if you look at the far side, and it's looking at Americans' rating of quality of healthcare in the United States since 2013. And I apologize. So you can see, and I apologize because I said since 2013 because that's a label, but really this top graph goes back to 2001 and the bottom one goes back to 2002. In this graphic, what you're seeing is that folks are not generally satisfied. So the top one, 53%, right, but it was oscillating, said their care was good. On this secondary one, you can see, and this is very specific data from the Gallup survey, which is why it's a little bit dated, but very interesting. This has been published and shared. On the bottom one, you can see that overall satisfaction and dissatisfaction, the percent dissatisfied has gone up, the percent satisfied has gone down. And that's only gotten worse really in different data sets since COVID. Now, this is data that we've been tracking for a long time, but got a lot of attention between 2010 to 2015 because of the implementation of the ACA. And there was a lot of uproar there. Now, the ACA focuses, and there's a lot of provisions in that law around mandating quality improvement. So we have to fix processes. We have to publicly report data to the federal government. We have to institute some sort of value-based purchasing where we're getting paid as facilities based on care provided, not based on the service provided, but based on whether or not we kept the patient healthy, right? We kept them free from a hospital-acquired condition or an infection. Now, when we look at measuring and incentivizing quality, one of the things that changed in 2014 with the ACA is they moved forward with this new national quality strategy. And it involves the three-pronged approach of better care, quality, healthy people, healthy communities, which I think of as access, and affordable care, cost. So for years, we've been saying cost, quality, access are our three areas. They put those into the national quality strategy. They just kind of rolled in this healthy people population health view on top of that, made it very patient centered, which is great. So this is our new aim from the federal government's perspective. The measures that we're collecting are looking at meeting these. Now, these last slides here, this last slide, this is an example of a quality improvement presentation that I gave. It's very tiny. But I gave this presentation at the National Association for Healthcare Quality back in 2019. This is a data collection effort that I did looking at improving the management of diabetic patients in a hospital and implementing a unique approach to managing their medication. You can't see it because I want you to see a high level. You can't see the individual tools, but I developed a workflow, current and future state. I tracked data over time and did statistical process control to see how the blood sugar values improved, see how costs were reduced. I did a root cause analysis to see what the fundamental drivers were and how we could address those. So lots of interesting tools. In our healthcare quality improvement class, we dive into, and especially if you take that course with me, I review each of those tools, how you leverage them, and you learn them so that you can use them in your career. But I hope this was an exciting kind of prequel for that if you haven't taken that class already, so that you can think through that process. All right, well, I hope this was helpful. Thank you so much for joining me for a short overview of quality improvement in healthcare.